Hello, Dr. Prakash Yadav. I welcome you to the MedEdge podcast. Start with a brief introduction about who Dr. Prakash Yadav is and where does he work. I am Dr. Satya Yadav. I work in India as a pediatric bone marrow transplant physician at Medanta Hospital in Gurugram. We treat children with blood and cancer disorders and we perform bone marrow transplant for children. Let's get into the topic directly, I believe. What are the therapies we use as a bridge to BMT, that is bone marrow transplantation, for a child with leukemia? Okay, so as you know, leukemia or blood cancer is the commonest cancer in children. Okay, and there are two main types: acute lymphatic leukemia (ALL) and acute myeloid leukemia (AML). Acute lymphatic leukemia is highly curable with chemotherapy alone. So 90% of children are cured with just medicines, chemotherapy. They don't need bone marrow transplant. Okay. But 10% children, they relapse or they do not respond to chemotherapy. So when the disease comes back, it is very strong. It is unlikely to be cured with chemotherapy. Such children benefit from bone marrow transplant, and that provides an immunotherapy, like the new bone marrow from another donor, from a brother, sister, or outside the family, brings a new immune system which can kill the cancer and finish the leukemia. So that's why bone marrow transplant is curative in leukemia. Okay. Same in acute myeloid leukemia, AML. That's a stronger cancer. Just around 60% can be cured with chemotherapy alone, no transplant required. But in 40%, it comes back, relapses, or does not respond to chemotherapy. There we offer them bone marrow transplant. So this is where we offer transplant. Now, how to make these children reach transplant? Because to do transplant, we need to control the disease before performing bone marrow transplant. If they have active cancer, then transplant is unlikely to be successful. We have to bring down cancer to very low level before we do transplant. So in acute lymphatic leukemia, nowadays there are a lot of great options, treatment options available as a bridge to transplant, where these medicines help to control the cancer beautifully before performing transplant. Like we have some antibodies. Okay, these are the antibodies against the cancer. Like cancer has a protein called CD19 against which there is an antibody called Blinatumomab. We give an injection of this medicine for 28 days continuously, and this brings cancer to very low level or zero level. Okay, and then we perform the transplant with good success. So the conventionally we were using chemotherapy again to control the disease before transplant. That had less success. With immunotherapy, success is more, at least 20% better survival. Okay. Similarly, you have CD22 antibody available, Inotuzumab, which can help control the disease before transplant. And we have a cell therapy called CAR T cell therapy. CAR T cell therapy is, we take out patients' own immune cells, we genetically modify them in the lab so that they can kill the cancer, target CD19 on the cancer, or CD22 on the cancer. Okay. And we put these cells back into the patient and they can kill the cancer and finish it. Some children can be cured permanently by CAR T cell therapy. They may not need bone marrow transplant. You can. But in those where the cancer is still detectable, we can perform a transplant after CAR T cell therapy. So these are the new treatments which are available, and they are the bridge to transplant for leukemia. Okay, so it avoids the second stage of chemotherapy. Yeah, it avoids stronger chemotherapy, side effects of chemotherapy, and it is better than chemotherapy. That's why it's a great improvement in medical science and great option for patients who relapse. Okay, that's great. That's great. So let's jump into the next disease, that is sickle cell disease. What is the additional therapy that's also given in the sickle cell diseases? So great. Sickle cell disease, as you know, it's very, very common globally. Like more than 300,000 children are born every year with sickle cell disease in Africa, India, and other parts of the world, Middle East also. And it's a lifelong disease where children suffer with recurrent bony pain, crisis, breathing difficulty, need for blood transfusions. They can have a stroke causing paralysis, or they can die from it, on sickle cell disease. What is it basically? It is basically a sort of cancer. It is a blood disorder where we all have red blood cells of hemoglobin which carries oxygen. Okay. And we all make normal hemoglobin. That's why we are normal and we don't need blood transfusions. But in sickle cell patients, they don't make normal hemoglobin, they make sickle hemoglobin. because they have a mutation in the genetic code of their red cells.
Okay.
And this sickle hemoglobin makes these cells very sticky. So when the cells are going through the narrow small vessels, they stick to each other and they can stop the circulation and
Okay.
cause pain, because oxygen is not going to that part of the bone or that part of the brain or lungs, and you become very sick. And these cells break down easily, and that's why you need blood transfusion. So that's what sickle cell disease is.
Before that, accordingly, in the part which it sticks or breaks the flow of blood, there the pain is caused. For example, the paralysis.
Because the oxygen cannot go in that part of the body, because it blocks the vessel, the sticky red cells.
Okay, got it.
So this is the sickle cell disease. It's very common around the world, but not everyone needs bone marrow transplant.
Okay.
All the patients should be given a trial of medicine called hydroxyurea. Hydroxyurea is a small capsule which they have to take every day, and this medicine stops this sticky part. The cells are no more sticky. The risk of crisis reduces, and they are very comfortable. So those patients who do very well on this, they don't need transplant. Majority of patients do well on this medicine, so they should be given this hydroxyurea medicine every day. And if they do well, they don't need transplant. But if they, despite the medicine, they are having problems, then we offer them bone marrow transplant. So this is my message to all the patients with sickle cell disease. Go to your doctor, take treatment with hydroxyurea, and if you don't benefit or you still have problems, then choose the option of bone marrow transplant.
Okay, if I'm getting it right, just the pronunciation, hydroxyurea.
Hydroxyurea, yeah.
Okay, hydroxyurea for the people to understand it better.
It's a very low cost medicine, easily available.
And it's very effective also.
Very effective, yes, yes.
Okay. Let's get into the next disease, that is Thalassemia Major. So, what is the pre-transplant immunosuppression if in that way?
Thalassemia, as you know, is again a very common blood disorder in Middle East, in India, and other parts of the world, Far East. And thalassemia is again a hemoglobin disorder where instead of making normal hemoglobin, you are making beta gene mutation is there, and you make abnormal hemoglobin.
Okay.
And your blood cells break down before they reach circulation.
Okay. So in sickle cell, it binds together. In thalassemia, it breaks down.
Breaks down even before reaching the circulation. In our bones, we make blood.
Okay.
So it is found there and gets destroyed there.
Okay.
And it doesn't reach circulation. So you need blood transfusions every month to survive, to live. If you don't give blood transfusion, you'll die.
Okay.
Thalassemia is a lifelong disease where you can only live with blood transfusions. And as you know, blood is not easily available in all parts of the world. And going every month to hospital to get a blood transfusion not easy.
Okay.
And they, despite this blood transfusions, they don't live beyond 25 to 30 years because the blood brings iron, and iron overload happens in the heart and in the liver, and liver and heart fail by the age of 25 years. So that's the problem with thalassemia patients. They can't live very long life with blood transfusions.
Okay.
So bone marrow transplant is permanent curative treatment. Okay, when we give them bone marrow transplant from brother, sister, or outside the family donor, or from parent to child, it offers a new bone marrow which makes normal hemoglobin, and they are cured. They don't need blood transfusions. They can live a long life, 70, 80 years like other family members.
Okay.
Now, in thalassemia, there are some challenges in their transplant.
Okay.
So there are three things. One is, how much is the iron overload before transplant? If they have received a lot of blood, like once the older patients,
Okay.
if we do transplant before 5 years of age, they have received very less blood.
Okay.
So there is more success in transplant.
Okay.
If we do it in a 15-year-old, they have received a lot of blood. So they have a lot of iron overload in the heart and the liver. So their transplant success is less. So early transplant at an early age is very good. Second is how much damage this iron has done in the liver.
Okay.
So if they have a big liver or the liver is fibrosed, then that means they will have difficulty in transplant. So before transplant, we should check that what is the size of the liver and how much liver is damaged.
Okay.
And what is their iron level.
Okay.
So if these three things are present, then it is known as class 3 patients, and they do poorly. Their outcomes are 60% survival.
Okay.
If these things are not there, 90% survival.
Okay.
So huge benefit. So such patients who are like having all these bad things, if we want to do transplant in them, then we should give them intensive chelation. That means we give them injections to take out extra iron of their body for at least 1 or 2 months before transplant.
Okay.
And we have to suppress their immune system so that they don't reject the donor cells, because you've got so much of blood before. Their immune system very smart. It can kill any blood.
Yeah.
So they can kill the donor cells also very fast. So that's why we need to knock down their immune system. So we give them pre-transplant immune suppression. We give them some injections, some tablets for about 6 weeks before transplant, so that their immune system is weak and they cannot reject the donor cells. So that's why, especially if you're doing a donor if you're doing transplant for a 15-year-old, they can reject the donor cells very high chance. So in some,
Because their immunity is
very strong. So we have to give them pre-transplant immune suppression before doing transplant, and that improves the success from 60% to about 80%, 20% gain.
But in a 15-year-old, the iron overload is less, but the immunity is strong.
No, iron overload is also more, and immunity is also, their immune system is very smart. So for iron, we give them injections to take out the extra iron. We remove the iron with injections.
No, I meant compared with a 50-year-old. A 50.
Yeah. 50-year-old, we can't do transplant. Okay, they cannot handle. They don't live till 50 years, thalassemia patients. So
Okay.
early transplant, like if they're 2 years, 3 years, before 5 years of age, 95% success. So they should, all the parents who are listening to our podcast, I like to tell them, if your child has thalassemia, do transplant early, before 5 years of age, and you have huge success. And it is a life-changing event, permanent cure, best possible treatment for your child.
Okay.
Thank you.
And these are the bridges that we have.
Yes.
The iron overload
So
treatment.
these are the things before transplant, how we should prepare the patient. So give them good medicines which can take out the iron, suppress their immune system, and then do the transplant.
Okay. So the difference in sickle cell anemia, sickle cell disease, and thalassemia is that in thalassemia, you have to go for bone marrow transplant as soon as possible. Whereas in sickle cell anemia, you have
we have a medicine, and if you do well on medicine, no need for transplant.
Okay, great. So let's get into the next disease, that is immunodeficiency that a child suffers. Why the bone marrow transplant is emergency in that particular case?
So when a child is born without immune system,
Okay.
there are children born like that. They have zero immune system.
Okay.
It is called severe combined immune deficiency, SCID disease.
Okay.
So our immunity has two parts. One is cellular immunity. We have cells which can kill bacteria and virus.
Okay.
And we have humoral immunity, where we make antibodies against virus, bacteria. So we have antibodies which can kill the virus and bacteria.
Okay.
So these children are born without both. They can't make antibodies against infections, and they don't have T cells to kill the virus or bacteria.
Okay.
So they cannot fight the infection. And any infection
Can
can
stop
kill
there
them.
and ask what is the reason for that they are born?
Yeah.
Because of the genetics of
Genetic mutation. So they have a mutation in the hematopoietic stem cells, where they cannot make T cells and B cells. B cells make antibodies, and T cells kill the virus and bacteria. So they can't make them properly, and they don't work properly. That's the problem.
Okay.
So if a baby is born like that, they usually die in the first 1 year of life with infections.
Okay.
So it's, as soon as we suspect or diagnose, we should send them to a transplant center, and it's an emergency transplant. Within a week or 2 weeks, we should do a transplant. Give them a new immune system from a brother, sister, or a healthy person. And that new bone marrow will bring a new immune system, and they will be cured. So people think, like parents, oh, our child is just 2 months old, 3 months old. How will he tolerate transplant? He will die during transplant. It's the other way around. If they don't do transplant, their child will die.
Okay.
So early transplant can save life of a child born without immune system.
Okay. Yeah. Okay. Great. So let's get into the next one. What are the strategies we use to have best outcomes for children with primary immunodeficiency disorder?
So we have discussed one, which is severe combined immunodeficiency.
Okay.
There an early transplant is a must.
Okay.
But there are other immune deficiency disorders like Wiskott-Aldrich. So in Wiskott-Aldrich, these children are born with low platelets. Their platelets are less. They have skin eczema, skin infections.
Okay.
And they have recurrent pneumonias, chest infections.
Okay.
So they are diagnosed around 3-4 years of age.
Okay.
Because it's not very strong in immunodeficiency, but it still causes problems. And by the age of 5-10 years, they die. Okay. So in them also, before, they all need transplant to be cured, but before transplant we can protect them from infections by boosting their immune system by giving them IVIG injections, intravenous immunoglobulin injections that boost their. These are the antibodies given from outside, so they can fight infections. Okay. So we can give them antibodies, we can give them some antibiotics and good care, and then do transplant at the earliest age. Similarly, there are other disorders like hemophagocytosis (HLH). It's a autoinflammatory disorder. That means your immune system is hyperactive, but it is unable to kill the bacteria. It is working, but working useless. It is harming our body, but not killing the bacteria. Okay. So it's a wildfire. Your body is on a fire. Your immune system is harming your own body and then not killing the bacteria. That is hemophagocytosis. You're eating your own blood. Okay. So here it's again sort of a very dangerous disease, because if you start eating your own blood, you will die. Yeah. So we have to put this fire at rest. So there are good medicines available to control it before transplant. Okay. If we do transplant in the middle of the fire, the transplant will be failure. Okay. So we have to control it. So we have medicines, antibodies like alemtuzumab, which can put this fire on rest. Steroids, dexamethasone, ipilimumab, which is again an antibody which blocks TNF alpha. So these are the medicines which can be used as a bridge to transplant in HLH, hemophagocytosis. We can control this fire, and then we change their immune system. We bring a new immune system which can kill the bacteria, virus, and they don't have this hyperactivation of immune system. So preparation is key. Early referral is key. You should, as soon as the pediatrician or the physician diagnoses immune problems, they should send these children to a transplant center where BMTs or bone marrow transplants are done for immune disorders. Okay, a specialized center, and they can be offered the best treatment, and we can help them survive. Okay. I appreciate you for your time. I have got a ton of knowledge, but before winding up, I would like to know your day-to-day routine in your professional career. Yeah. So what we do as professionals, I've been in this field for more than 25 years. So we, first of all, we see patients in the outpatient. The patients come to our hospital for checkups. So we diagnose various kind of blood and cancer disorders in children. Okay. So we do the test, we check them, suspect what can be the cause. So first you have to diagnose what is the problem with the child. Okay. And then we offer them treatments. So as I said, many of them can be treated without transplant. So we offer them chemotherapy, tablets, injections, other things, and try to control their symptoms. Those mostly on OPD patients, so we don't admit them, try to treat them without admitting them. But those where the disease is severe or big disease, we admit them and give them treatment in hospital. When they're admitted in the hospital, we see them in the morning and the evening, twice a day. And we have a big team of doctors. We discuss their disease in great detail. We make a treatment plan. We do a lot of research to find new treatments for these patients. We inform the family about the progress of the child, what is the disease, what is the plan, what we're going to do, how the treatment is working. And those patients who need transplant, we offer them bone marrow transplant. So it's a busy day and years we put in, but it's very satisfying to see a small child born without immune system growing into an adult, healthy adult. When they come later on, they don't even remember us because they were 1 year old. They don't have any memory. We treated them. So their parents tell them, this is your doctor, he treated you. The patient is not even aware of that. Satisfaction. It is very satisfying. Many of them have become doctors, engineers. They've grown up into beautiful young people, and they had such bad disease where they could have died. So it's very satisfying to save life of children suffering from blood and cancer disorders or immune disorders with the latest therapies. It's very satisfying. Thank you. Okay. And this is from the professional perspective. I would also like to know from the personal perspective, like how do you stay motivated and health-wise, how do you cope up with? So I come from a place in India, which is a state called Haryana. Okay. And in that state, when I grew up, when I was a child, there was no buddy in my family who was in medicine or a doctor. And my elder brother, who inspired me, said that you have to become a doctor and serve people. And in this area, there are not many good doctors available for people. People have to go to bigger cities or other parts of the country for treatment. So if you can train, and that inspired me. And then after finishing my training in India, I went to Australia to train further in bone marrow transplant and learned how to do transplants and these latest treatments. And then I came back to my country. I trained another 30, 40 doctors, and they are working across India. So now there are a lot of doctors who are treating these children. And it's very satisfying that as a personal goal, I wanted to help patients across India, across the globe. Many of my trained doctors are working in Abu Dhabi, also here in Burjeel Hospital. Three doctors are working. That's great. So some are working in Australia, some in Canada, in Singapore, all parts of the world they are working. So it is very satisfying that to train people and to motivate them to train more doctors. They are further training. So it's a chain because world needs good doctors and best possible treatments for the children. So that's the goal. Thank you.
Thank you. Thank you very much for your time. I have got a ton of knowledge from you. I believe the audience also. Uh, I wish we could sit another time and get to know more about such things. Thank you for very much for your time.
Thank you. Thank you to everyone who's listening to our podcast. Thank you.